So some excellent presentations. We have about 5 minutes for panel discussion and questions. If you have any questions, please, there's a bunch of mics in the audience.
Thank you for a very educational session. My question, Dr. Henry, is sometimes, like you said, these STEMIs, we fix them very quickly, and if you're using Angiomax, you just hardly drip it for 10-15 minutes and you're done. Would you keep giving Angiomax for a little bit longer time, or would you stop it and just be done? Thank you.
It's really important. I run out the vial. You've paid for it anyway. I don't do the extra 4-hour thing. I just run out the vial.
So at the risk of prolonging the session until tomorrow, Tim, I'm still having trouble understanding why you would use Cangler when you can just give a bolus of 2B3A.
Yeah, really, you know, for me it has to do with, I think P2Y12 inhibition is it's so potent. If you look in particular in tirofiban and haven't compared it, there is not a good study that compares the two, and that's certainly one. But the cost for Integralin and the cost for ReoPro is just as high. I don't think there's really evidence using short, like boluses of 2B3 inhibitor, and you clearly increase the bleeding.
Yeah, so if you go radial access for STEMI and you give tirofiban, which is $250, and you load the patient after the PCI, the bolus of tirofiban lasts 6 hours. Whatever P2Y12 you use at that time will kick in by then. So I'm just having trouble why I would go to my P&T committee to try to get a new antiplatelet agent on board when I've got 3 2B3 inhibitors on formulary already.
Yeah. The tirofiban argument is a valid one. But again, remember, I think if you use pretreatment appropriately, you should have adequate on board without using anything, I think.
Before Angiomax?
Heparin before bivalirudin.
Yeah.
So that's a really good question. You know, there was some data in Horizons that showed if heparin had been that there was some benefit. I think personally, this is my bias. That was targeted to because what happens when you give heparin, you're also giving your first P2Y12 inhibitor. But there's no reason not to get heparin, and all of the places that I know that in their standardized protocol in the pre-hospital setting or in the hospital before you transfer them, at first medical contact, should get an IV bolus of heparin, should get aspirin, and should get whichever P2Y12 inhibitor you happen to use. You know, I'll leave that to what your local standard is, but an IV bolus of heparin should be included in that first point of care plan. Yes.
So Tim, I have a question for you. So you made a strong case to use bivalirudin, but most of the trials compared bivalirudin versus a combination of heparin and a 2B3A. And the 2B3A is what made the difference. I know the HEAT-PCI had many problems and has been contested in many ways, but I think that the bivalirudin use has dropped significantly lately with use of transradial access and lack of use of 2B3As. So you still use bivalirudin?
I still do, and I think because of Bright, and I think radial access decreases the need somewhat, but half your bleeding is still in another area. And the second point I would say is if you look at the Bright trial, there's still decreased bleeding even if you're just using heparin alone.
There is some role of nitric oxide by giving the heparin, and that is not liberated with Angiomax.
It's Roxana.
No, I just want to say that the trial to wait for is Validate, which is going to be coming up very, very soon with the Swedish group doing this very good large scale study in STEMI patients, including everyone and not excluding anyone, and doing a randomization of heparin versus bival. So we'll see that, I think, very soon.
So I have a question for you, Tim, versus Navin. So I'm wrestling here with time is muscle. Your patient that comes in shock, are you going for the impella, or are you going to open up the artery? Detroit's shock initiative is clearly showing us time to unload is first. I would have a hard time waiting 30 minutes to open up the artery myself. So my question is, what should we be doing? Should we be getting another tending in there to one, put in the impella or put in the support device, whatever you may use, and one to open up the artery? But at the same respect, I'm going radial for my STEMI, so maybe I have the groin open for a partner, but that's not possible in the middle of the night.
So I will have people that disagree with me on this in the room. The most important is blood flow. Open the artery. And a lot of people that are in shock, especially mild shock, when you open the artery, they're immediately normal. It comes back right away. Now, I will also say, what?
Sorry to start this fight.
Yeah, no, I know you're going to get controversy. Yeah. There's people who say that you should do the unloading first, and that's been a long time theme. It used to be you should do the balloon pump first. The other real life point about this, you do parallel processing, right? If you have a sick person in, but I'm not going to sit and wait to put the Impella in and not open up the artery at the same time.
Why does it take you so long to put the Impella in?
Well, you can do both at the same time.
It shouldn't take long at all,
For sure,
actually.
you can do parallel processing. But I wouldn't wait to open up the artery.
Navin, what do you do?
Yeah, so I think this is a great question. It's obviously one that requires more data. I think the Detroit Shock Initiative is critical because it's going to start to answer this question with some definitive observations. I agree with Tim completely that blood flow is the key, and you've got to get in better blood flow. My argument here would be that the way to do that is actually to unload the ventricle, and you'll actually get better myocardial perfusion. So I think there are two ways to do it to get better blood flow. One is to take away that workload of the ventricle. You're actually going to enhance microvascular flow and to open the artery as quickly as possible. So for us in our lab, it takes us about 8 minutes to put in an Impella, and it takes us about 4 minutes to get radial access. We're doing this now. This isn't an empiric experience that people are having now. I think if you're in a condition, like you said, it's the middle of the night, you don't have a second operator, you're by yourself with your team, I think it really just depends on how critical the scenario is. If you've got someone with a prox LED occlusion that's in crash and burn shock, impending intubation, or already intubated and not doing well, I would get that patient on support, stabilize the blood pressure, open the artery. If the patient is looking at you and they've got a blood pressure of 88, and this is where the numbers, I think, cause problems because people hang their head on a number, I think you're fine to go ahead and open the artery, get the patient stabilized from a coronary perspective, and then start to assess the ventricle. But we don't have a formal algorithm, and the Detroit Shock Initiative is as close as we've gotten so far to that. But I think Tim also showed it very nicely with his ECMO experience from Minneapolis, that in a lot of patients, if you can stabilize their hemodynamics and then go ahead and open the artery, you're going to see better recovery. And hopefully you're not doing it with Lucas patients only, but now that should start to extend to your patients who have STEMI and shock, not necessarily out of hospital arrest.
So on the same lines, I did have another question. So how do you guys decide in STEMI patients that which patient need to go femoral versus radial, especially in the radial first centers? How do you decide that? Is there any way you decide, or you just look at the patient and decide on that? So, thank you.
I think it's radial first. I mean, I think you answered your question when you just mentioned that. I think, depends on expertise. You don't want to start your radial learning curve with a STEMI. I mean, that's an obvious thing. But if the patient has a pulse and the patient, and you think you or your team feel capable of getting access and you've done it 100 times at least, I think you can confidently do a STEMI via radial access. Once you need to know some navigation trips, and you need to know that tortuosity depends on height, age, and gender. So little old ladies, you may go to the left side.
So let me put it a different way. I'm asking, is there a patient that you will go femoral first or not?
No radial pulse.
Yeah. Well, even with radial pulse, you can use ultrasound. I don't think I don't see a patient which I would go femoral first.
I think the previous bypass patients, that's the one group for a STEMI, I would go femoral, because by the time you get the grafts and everything, it may take you several minutes and be a long time.
Makes sense.
But otherwise, I completely agree. STEMI is the one group where the benefit is the most, and radial is the way to go.
So my question is about orbital atherectomy. So let's say you do orbital atherectomy and you have angiographic improvement, but you're still not able to get your stent in place without use of a microcatheter. Would you go ahead and stent at that point, or what else would you do? What would you do next?
No, I think the reflex is to do that, and I'd love to hear from other people on the panel. This is independent, I think, of OAS or ROTA. I think if you're really having trouble delivering devices, that means you simply haven't prepped the lesion enough. So I would probably repeat the atherectomy, use a non-compliant balloon, but I think the reflex to go to putting a stent in at that point is going to really end up in a bad situation. Luckily you're not, all of us have time pressures in the lab, but these complex cases with calcification, you really need to take your time and prep the lesion adequately. And sometimes, for imaging is very helpful. Great. Thanks so much for attending the session.
Great, thank you.